Thank you, ma'am. So very common topic, dengue. Every year we are making roster, dengue roster. With July, August, we start keeping roster, and all the medical departments are contributing in managements of our dengue patients. So I thought will be a topic of interest for most of us. We have overall our CGR will have 3 components. We briefly talk about dengue fever, which I will talk about. Then dengue hepatitis will be talked about Dr. Surender, and SGPGI experience of dengue hepatitis especially will be talked by Dr. Ajay. So this is the dengue virus, which belongs to flavivirus family, Flaviviridae. From those from gastroenterology must know this hepatitis C virus also belong to the same family. A small virus of around 11,000 base pair nucleotide and single-stranded RNA genome, which have 3 structural protein and 7 non-structural proteins. And there are 4 serotypes, dengue virus 1, 2, 3, and 4. In India, the most common was 1, but now it is changing from 1 to 4, and other serotypes have also been reported from India. What is important here to know, when we have infection with one serotype, it gives lifelong immunity for that serotype, but a short-lasting immunity for other 3 types of serotypes. And second infection with another serotype lead to severe dengue because of pre-existing antibodies. They are vector for this virus, which is transmitted through mosquito. Aedes aegypti and Aedes albopictus are the 2 most important vectors. Aedes mosquito is not the vector only for dengue, but other 22 types of arboviruses, which are commonly causing other prominent diseases like Zika, chikungunya, yellow fever, etc. This is important slide, I thought very useful for us to understand what is the difference between Aedes aegypti and albopictus. Aegypti was originated in Africa, and from there it transmitted and spread to all over the world. It is highly domesticated, so it lives comfortably inside the house as well as outside the house, and is strongly anthrophilic. That means it has a strong propensity to bite human beings. It need to bite more than 1 host to complete 1 blood meal, and need more than 1 feed to complete 1 gonotropic cycle, means reproduction cycle, right? That means it is much more likely to bite more people than Aedes albopictus, which originated in Asia and then spread to rest of the world. Now both the vectors are contributing in different proportion in different countries for the burden of disease. It is less domesticated, and it preferably live outdoor. It prefer to feed on feral, but can feed on human being and animal both. It completes its blood meal in 1 go, and complete gonotropic cycle in 1 blood meal. If we see the disease burden at global level, 4 million people, this number I have made a little bit smoother so that we can keep it in mind. 4 billion people are at risk. 400 million people acquire infection every year, and 100 million symptomatic infection occur every year. 0.5 million are hospitalized each year, and approximately 40,000 deaths occur in a year globally. Where it happens at global level, if we say, it is most commonly affecting the countries which are in tropical zone and subtropical zone. At the equator level, both sides approximately 25 degree north and 25 degrees south are the tropical zone, where temperature is roughly up to 26 to 24 degrees centigrade. And 10 degree further means up to 35 degree on toward North Pole, and 35 degree toward South Pole is the subtropical region. And this is the country which are lying in this region marked here are the most affected. Most of the burden, 80% of the burden lies in these countries. In epidemiology, if you see in India, entire country is almost uniformly affected, barring few states, which is more likely to do the lack of data, lack of reporting. Instead of that, they are immune to the disease. Like you see Jammu Kashmir and some of the state in Northeast region. National Center for Disease Control data, if you see annually from 2018 to 2023, it is gradually increasing, barring 2020. Because of COVID pandemic, the number was less. Whether it was reduced outdoor activity, real reduced incidence of disease, or it was reduced reporting or reduced access to the healthcare, we don't know what was the reason. Probably the other factors are more important. In India, further, you see that the number of cases start increasing from July and continues up to usually November, December. The cycle of transmission, once the infected human being is bitten by a mosquito, it takes blood meal and takes the virus. Virus infect and replicate in the intestinal epithelial cell lining. Then it circulate into the hemolymph. From there, it is circulated to the all other organ, and every other organ is infected inside the mosquito, and the mosquito remain infected for rest of the life. This is the extrinsic incubation period of 8 to 10 days. When this infected mosquito bite another uninfected person, it inject a small amount of saliva as an anesthetic agent at the site of bite, which inoculate virus in the blood circulation. And after that, the uninfected person get infected and starts presenting symptom and incubation period of 4 to 7 days. If you see the entire clinical spectrum of dengue infection, a large proportion is asymptomatic. Roughly 75% of infections are asymptomatic, 25% are symptomatic. Symptomatic infection can be undifferentiated fever, dengue hemorrhagic fever, or expanded dengue syndrome. Undifferentiated fever is most common in young infant or children, when this febrile illness is not different from any other febrile illness which occur in that age group. Even the symptom may be related to URTI or may have GI symptom, no symptom of dengue fever may be present. Dengue fever, classical dengue fever, it present in older children, adults, adolescent age group, and typical fever of dengue, low platelet count, high grade fever, with chills, rigors, retroorbital pain, myalgia, etc. are seen. In dengue hemorrhagic fever, other than in addition to the symptoms of classic dengue fever, we also get features of bleeding or plasma leakage in form of shock or petechiae, GI bleed, other source of bleed. Expanded dengue syndrome is the new entity which was described as when we have any other organ system which is markedly involved, like myocarditis, encephalitis, pancreatitis, or hepatitis, with or without plasma leakage syndrome or bleeding or any other manifestation. And this is the classification given by WHO in 2009, how to define severe dengue and non-severe dengue, and which we have used in our data presentation. So I'm summarizing here. The severe dengue is classified as those having dengue shock syndrome or fluid accumulation in chest cavity or abdominal cavity, which is so much significant that is causing breathing difficulty, or any other severe organ involvement, or ALT or AST more than 1,000 international unit per liter. So these are the factors in literature which have been explored as a possibility for severe dengue. And these are categorized in 4 groups. Host factor like infant, elderly, female, pregnancy, diabetes, and obesity. These are the risk factor related to host, which may lead to severe dengue. Immune status of the host, prior infection, we all know, if the person was exposed earlier, then more likely to have severe dengue. This is interesting, prolonged interval between the 2 episodes, which lead to severe dengue. Genetic factor, non-African ancestry are likely to have more severe dengue, and certain HLA phenotypes are associated to found with. Viral factors, these are poorly examined, very limited data that the certain serotype, especially serotype 2, is supposed to be associated with severe dengue and level of viremia. So now I will request Dr. Surinder to take us forward with the dengue hepatitis part.
Thank you, sir, and good morning, everyone. So coming to the dengue hepatitis. So before I go into the definitions and other clinical spectrum, let us understand how the patient with dengue infection can manifest with the liver disease. So in a patient with native liver that is normal, if he or she develop dengue infection, then they can develop acute hepatitis, about which I will be talking in detail in subsequent slides. And on top of that, if they develop coagulopathy, that is, if they develop INR more than 1.5, then they are said to have acute liver injury. And subsequently, if the patient goes into any grade of encephalopathy, then the patient is said to have acute liver failure. So from acute hepatitis, the patient can go downwards to acute liver failure via acute liver injury. So as the spectrum changes from acute hepatitis to acute liver injury to acute, the prognosis of the patient changes, and acute liver failure has a high mortality as compared to acute hepatitis. So coming to the definition, so there is no universal definition to define dengue hepatitis. However, the most accepted one used in most studies has been AST or ALT level that is more than 3 times the upper limit of normal. And this is the definition which we also have used in our data analysis. And depending on the grading of or the level of liver enzyme elevation, the dengue hepatitis has been classified into mild, moderate, and severe. Mild being 3 to 5 times upper limit of normal, moderate being 5 to 10 times elevation, and severe being more than 10 times upper limit of normal elevation. Here, the important point to note is that in dengue hepatitis, the serum AST is significantly higher than the serum ALT levels. And this is partly attributed to the release of AST enzymes from the muscles as well, which are involved in dengue fever. So hence AST levels are higher as compared to ALT. However, another point to be noted is that when the infection starts to resolve, the level of AST enzymes comes down before the level of ALT. This is because the half-life of ALT is more than AST. Hence, ALT levels remain elevated for a comparatively longer period of time as compared to AST levels. And now studies as well as meta-analysis have shown that level of liver enzymes correlate with the disease severity, and high liver enzymes are also a marker of poor prognosis in such patients. So we need to keep a look at the liver enzymes of patients presenting to us with dengue fever. So now coming to the pathogenesis of dengue hepatitis. So dengue hepatitis can occur because of multiple reasons in a patient with in a patient having dengue. First and foremost, they can have ischemic injury like any other patient who has any disease with hypotension or shock. So this can be because of ischemic injury secondary to dengue shock syndrome. Then another important cause is hepatic sinusoid endothelial dysfunction, which occurs because of the infiltration of the virus and endothelial dysfunction occurring because of cytokine storm. Third one is the direct cytopathic effect of the virus. So virus infects the hepatocytes and it causes the release of pro-apoptotic factors, which in turn causes the apoptosis of the hepatocytes, leading to the cell death. And the fourth one is the immune-mediated injury, which is because when the liver cells are infected, so the body has its mechanism to fight with the viruses. So as the body tries to eliminate this virus from the body, so there occurs the destruction of hepatocytes also. And as sir also mentioned that a person who has had a previous dengue infection and he or she develops another dengue infection with a different serotype, so they are bound to have a severe disease because of antibody-dependent enhancement of the virus, because the previous antibodies, when they bind to the new serotype, so they cause facilitation of the virus inside the hepatocyte, which leads to the severe disease in such patients. So if a patient with dengue fever presents to us with acute hepatitis, we have to rule out other causes because we cannot be sure that this is because of dengue hepatitis or some other cause. So first and foremost, we have to rule out acute viral hepatitis because the presentation is very similar. And in few instances, co-infection has also been seen that a patient has dengue fever and he also has acute viral hepatitis. So one important point which can help us to differentiate clinically is that in acute viral hepatitis, fever will usually be there for 2 to 3 days, and after that fever subsides and patient develops jaundice and subsequently goes into acute liver injury or failure. Whereas in dengue, the febrile period can be variable and it is usually for 5 to 7 days, and the AST enzyme level will be more than ALT, whereas in acute viral hepatitis, usually it is the other way around. Then coming to the second important DD, which is the tropical infection. So we know that along with the dengue, we also have fever, causes of fever like malaria, scrub typhus, leptospirosis, and chikungunya in our country. So it is important to differentiate these infections from dengue hepatitis because we know that specific treatment is available for these infections. So if we are able to make a diagnosis of these, we can give a specific treatment and the prognosis of the patient improves suddenly. Third one is the drug-induced liver injury. So we know that since the advent of COVID pandemic, there has been a boom of use of herbal supplements as well as other kind of immune boosters which are being used by the patients. So after that, we have seen that data is available that there has been a sudden rise in drug-induced liver injury. So we always have to ask any patient presenting with acute hepatitis about significant history of any herbal supplement or any CAM intake, because this also has a similar presentation with sudden jaundice. I can also have mild fever and all these presentations. Hence, meticulous history has to be taken in such patient. Then comes autoimmune hepatitis. So autoimmune hepatitis, we all know, can also present with acute hepatitis and can go up to acute liver failure also. So acute autoimmune hepatitis is also one of the important differential diagnosis in such. And so is acute Budd-Chiari syndrome, which can have ALF-like presentation with sudden onset of pain, abdomen followed by jaundice, and in some cases progressing to acute liver failure also. So these important differential diagnoses we have to rule out before confirming that hepatitis is because of dengue only. So now coming to the prognostic indicators. So various data and studies which are available on dengue fever and dengue hepatitis. So after studying those articles, we have come to conclusion that severe hepatitis, the lactate levels at baseline, pH of the patient at baseline, MELD score, number of organ failures, presence of any secondary infections, and the development of acute liver failure are all a portender of poor prognosis. So if any of these are available, that we should be very careful in such patients, and they require urgent ICU care and meticulous treatment. So now coming to some of the studies and meta-analysis which is available on dengue hepatitis. So this was a meta-analysis which was published in 2016 by Wong et al. And this article basically studied the proportion of patients with dengue fever having enzyme elevations. So they studied 15 articles in total, and out of these, for ALT elevation, it was divided among patients with dengue fever and dengue hemorrhagic fever. So 11 articles were available that had data on ALT elevation in dengue fever, whereas 6 articles were having data on ALT elevation in dengue hemorrhagic fever. Similarly, 8 articles had data on AST elevation in dengue fever, and 5 articles had data on AST elevation in dengue hemorrhagic fever. So what this meta-analysis found out that ALT elevation in dengue fever are present in 52% of the patients with dengue fever. And this percentage increased only marginally to 54% in those patients with dengue hemorrhagic fever. However, when they analyzed the AST elevation, it was found that it was elevated in 75% of the patients with the dengue fever, and it further increased to 80%. So clearly we can see that there is high proportion of patients with dengue fever having elevation in AST and ALT, with AST having up to the 75 to 80% of the patient having AST elevation, and around 50 to 55 having elevation in ALT levels. So the proportion of patients in dengue fever having liver involvement is quite high. Then this is another meta-analysis which was done to assess the predictors of progression to severe disease in a patient with dengue. So they analyzed around 122 studies in this meta-analysis, and after analysis of the data, they identify around 25 potential predictors that were indicators of progression to severe disease. So they divided these predictors among demographics and comorbidity, signs and symptoms, laboratory parameters, as well as virological profile. And laboratory parameters, they came to conclusion that AST, ALT level is a significant predictor of disease progression to severe disease in such patients. So the forest plot also shows the same that AST, ALT level was a predictor of severe disease in such patients. However, then comes the important question, what level of AST, ALT elevation is associated with risk of progression to severe dengue? So there is no clear-cut answer for that. We have to closely follow up such patients, those who have any elevation of more than 3 times of baseline, and then we have to see the trend. If there is an upward trend, there is always a high chance of going into severe dengue and subsequently dengue associated acute liver failure. So then this was another study done at St. John's, Bangalore, and they analyzed their 4 years of data of dengue patients of around more than 10,000 patients. And they found out that out of 10,108 patients, only 36 patients progressed to acute liver failure. which was roughly 0.35% of the total patients. So although the proportion of patients developing acute liver failure was quite low, but the important point to consider is that out of these 36 patients, 21 patients could not survive. So mortality rate was almost 60%. So although the patient progressing to acute liver failure is quite low, but the mortality rate is quite high. So this signifies the early identification of dengue hepatitis and keeping a close watch on such patients, whether they are progressing to acute liver injury and subsequently to acute liver failure. And as per the analysis of this study, lactate levels, pH, and MELD score were the predictors of mortality in this study. So now, briefly, I'll be talking about N-acetylcysteine. So all of us are aware that N-acetylcysteine is approved for paracetamol, poisoning, and overdose, and is also used as a mucolytic agent in the pulmonary disease. And it is available in oral, IV, as well as inhalational forms. And the most commonly used dose which we use in patients with acute liver failure is 150 mg per kg in loading dose given in 30 to 60 minutes, followed by 50 mg per kg over 3 to 4 hours, and then subsequently 100 mg per kg per day infusion over 16 hours for 5 days. And this N-acetylcysteine, the side effect profile of this drug is very safe, and only minor side effects like nausea, vomiting, diarrhea can be seen. And only rarely in 1 to 2% of patients have anaphylactoid-like reactions have been seen, which manifest with pruritus, flushing, and rarely bronchospasm or hypotension. The side effect profile is quite safe and can be used in patients even who have multi-system involvement. So now coming to the mechanism of action. So how does N-acetylcysteine help in patients with dengue hepatitis or dengue associated acute liver failure? So N-acetylcysteine has basically 4 mechanisms of action by which it acts. First is its direct antioxidant action. So it itself acts as antioxidant and leads to the deactivation of the reactive oxygen species. Second is its indirect antioxidant action. It provides substrates for the glutathione reserve to be replenished in the body, and then glutathione acts as an antioxidant. So that is via indirect. Third one is its anti-inflammatory action. Its anti-inflammatory action is by suppression of the nuclear factor kappa beta, which is instrumental in synthesis of inflammation mediatory cytokines, and hence by inhibiting nuclear factor kappa beta, it leads to the its anti-inflammatory action. Third one, it is also been shown to have some vasodilatory and inotropic action, and it improves the hepatic perfusion. So these are the predominantly 4 mechanisms by which N-acetylcysteine acts. So now all of us are aware that the guidelines recommend NAC for the use of NAC for use in acetaminophen related acute liver failure. However, now data is also present where it has been recommended that it can be used in non-acetamin related acute liver failure. So one such meta-analysis I'm highlighting, which was published in 2021. So it took into account 883 patients with which were from the 7 studies which were included in this studies, and this included 2 RCTs also. So they came to a conclusion that overall survival was high in patients who were given NAC, and the odds of survival of NAC receiving patients was 1.77 times higher than those who did not receive NAC. Similarly, transplant-free survival was also higher in those patients who received NAC. It was 2.85 times higher as compared to the control group. So in this meta-analysis, it was also concluded that the hospital stay was also lower in patients with NAC. So this meta-analysis was instrumental in showing that the NAC not only decreases hospital stay, it also has improvement in patient mortality as well as transplant-free survival. So now coming to the use of NAC in patients with dengue. So initially there were only case reports that were available in which individual patient with 2 to 3 case patient with the 2 to 3 patients were treated at a center, and then data was available. However, now we have some descriptive as well as retrospective data that have shown that NAC definitely causes decrease in AST, ALT enzyme levels, and it also has a positive impact on the hospital stay by decreasing it. However, data is still not clear whether there is mortality benefit of using NAC or not, because some of the one study has shown that there is benefit of in mortality, whereas one study has shown that there is no benefit of mortality. But all of these studies have shown that it decreases the AST-LT enzyme level, and there is also a benefit in hospitals. So now briefly about histopathological changes in dengue hepatitis. So we usually routinely we do not do liver biopsy in patients with dengue hepatitis. All this data has been from the post-mortem liver biopsies that are usually done in patients those who do not survive dengue related acute liver failure. So what we usually see is Kupffer cell hyperplasia, portal tract inflammation, which is usually mononuclear, and macrovesicular as well as microvesicular steatosis. And then necrosis can also be seen with councilman bodies, and necrosis increases with increase in involvement of liver and disease severity. And then we can also see hemorrhages inside the liver parenchyma as seen in this pictograph. So now coming to our experience of handling such patient and data from SGPGI, I would like to invite my colleague, Dr. Ajay Mishra.
Very good morning to all of you. Now, presenting our experience of the dengue hepatitis management. First of all, I would like to explain that how we have classified the patients. We had 134 patients from August 22 to December 23, and we classified patients into severe dengue and those who do not have severe dengue. So these criteria that already been described are used for classifying the patients in the severe dengue. All those patients who had shock, effusions with the breathing difficulty, severe bleeding, or severe involvement of any organ, or ALT/AST more than 1000 have been classified as the severe dengue. And classifying the severity of dengue hepatitis, we classified all those patients who had AST/ALT enzymes more than 3 times. Up to 5 times we classified as mild, and from 5 times to 10 times we classified as the moderate dengue hepatitis. And all those patients who had liver enzymes more than 10 times of upper limit normal are classified as severe dengue hepatitis. And cutoff for the upper limit we have taken as 40 as per our lab reference. And we also categorize patients based on the warning signs, patients of dengue fever without warning signs, patients of dengue fever with warning signs, and patients of severe dengue. So warning signs have already been described. These are abdominal pain, persistent vomiting, clinical fluid accumulations, mucosal bleed, lethargy, liver enlargement, laboratory-wise increase in the hematocrit or rapid decline in the platelet counts. And the severe dengue has been described with the presence of shock, fluid accumulation, or patients with severe bleeding, and the patients with severe organ involvement, that is AST/ALT of 1000, CNS impairment, or heart and other organ impairment. So coming to our data, the 39 patients out of 134 had no warning signs, and out of them, 79% of the patients had involvement of the raised liver enzymes, that is AST/ALT more than 3 times. And out of them, 15% of the patients had mild hepatitis and 18% of the patient had severe hepatitis. So most of the patients lie in the moderate group in patients who did not have any warning signs. In all those patients who had warning signs, out of 134, 37 patients had warning signs, and out of these 37 patients, 95% patient had evidence of hepatitis. And again, in this group, 24% of the patient had mild hepatitis and 24 had severe hepatitis. Again, in the patients who had warning signs, most of the patient had the moderate hepatitis. In patients with the severe dengue, the 91% of the patient had the liver involvement. And in these groups, the 17% patient had the mild hepatitis and 33% patient had the severe hepatitis. Again, the moderate hepatitis is present in the larger patients, but these patients had the higher chances of having the severe hepatitis. Overall, the 89% of the patient had the evidence of the hepatitis, and the severe hepatitis was present in the 25% in the whole cohort, whole patient population. So this is quite high relative to the other studies, as we have already described. As the severe dengue has been defined by the STLT elevation more than 1000, we also distinguish the patients who had less than 1000 enzymes or those who had more than 1000. So out of 134 patients, 24% of the patients had the enzyme levels more than 1000. 58 had severe dengue and 14 patients out of the 58 had more than 1000 enzymes. And all these have been classified as severe dengue. Only 14% patient out of these who had liver enzymes more than 1000 died. So we also analyzed the baseline characteristic of the patients who had non-severe dengue and the severe dengue. Most of the patients are relatively 54% of the patients were male, and these patients are relatively younger, 35 years in the non-severe dengue, and also median values of severe dengue was also 35. Hemoglobin levels were 12 in the non-severe group and 10 in the severe dengue. The platelet counts are 90,000 in the non-severe group and 100 in the severe dengue group. TLC count is 5.5 thousand and 6.2 thousand. Bilirubin levels are elevated in the severe dengue group. The liver enzyme levels, although median values are non-significant in between the groups, but there were extremely higher values in the severe dengue group. So we classified them as a median values, and these median values are not different in between the non-severe and the severe group. Again, albumin levels are also comparable, 3.7 and 3. INR is 1 and 1.09. Creatinine is 0.85 and 0.89. So overall, 86% of the patients in non-severe group and 91% of the patient in the severe group had evidence of the hepatitis. So coming to the outcomes of the dengue hepatitis, out of the 119 patients who had evidence of dengue hepatitis, 30 patients had required the ICU admission. And those who required ICU admission, 27% had mild hepatitis, 30 had the moderate hepatitis, and 43% of the patients had the severe hepatitis. Overall, 9 patients died out of those who had hepatitis, and 23% of those who died had mild hepatitis, 22% had moderate hepatitis, and 56% had the severe hepatitis. So there is trend towards the higher mortality in those who had severe hepatitis. Coming to the other organ involvements, the renal failure was present in the 13% of the patients. Acute liver failure, which has been defined by the presence of jaundice, encephalopathy, and prolonged INR, was seen in 6 patients, which is relatively higher than the other series we have presented, because the incidence is less than 2 to 3% in other series, but in our series it is 5.1%. Shock was present in 9%, but this is likely to be underestimated because this is a retrospective analysis. So maybe we have some missing data for the shock, but it is, as per the records available, it was 9%. And the encephalopathy was found in 6% of the patients. Respiratory failure was recorded in 5% of the patients. So coming to the profile of our ALF patients, we had 6 cases of ALF. And these patients were relatively younger, except one patient who was 53 years age. Others were in the range of only 3rd or 4th decade. Hemoglobin levels were also lower. Most of the patients were anemic, and the severe anemia was present in 2 patients. One patient had the hemoglobin of 9.6. Leukocyte counts were also, most of the patients had elevated leukocyte counts. One patient had the HLH and had cytopenia. Platelet counts were variable, although the platelet count less than 20,000 was seen in 1 case only. Bilirubin levels were elevated, but most of the patients had bilirubin levels less than 10. One patient had the bilirubin of 31. So coming to the enzyme elevation, most of the patients had the enzymes more than 1000, and the maximum AST which has been seen in these patients was 41,340, possibly due to severe muscle injury. And the maximum ALT which was seen was 9,900 in patients with dengue ALF. Albumin levels were around 3. One patient had the severe hypoalbuminemia, which is 1.9. INR prolongation was also seen, and this is INR maximum was 4.45, and rest of the patients had say between 2.5 to 3. All the patients who had dengue ALF had the renal injury also. This is important because this is possibly secondary to the or multi-organ involvement and the severity of the dengue also. So most of the patients had the creatinine levels, which was high, ranging from 6.2 to 10.9. So we also calculated the MELD score, which is higher than the other series. And as we have seen already that MELD score in other series was 25 and 24. But in our series, it is every patient had the MELD score more than 30. So again, emphasizing that these patients were very sick. We calculated the fever to encephalopathy day. The on presentation at the time of fever and followed by the day at which the patient develops encephalopathy. So this data was available for 4 patients, and all of these patients had encephalopathy within a week of the fever. So these are likely the hyperacute liver failure rather than the simple ALF. So outcome wise, out of these 6 patients, 4 patients had poor outcome, including 3 deaths and 1 patient who went LAMA. 2 patients can be successfully discharged. And out of these patients, the 1 patient had the evidence of the CVA bleed also, 1 patient had GTCS, and 2 patients had the evidence of HLH also. So we tried N-acetyl-16 in 1 dengue ALF patient, which was admitted to our site. And we tried this in the doses already been advised for the as ALF protocol. And in this patient, the bilirubin level was 31 and AST-ALT levels were 569 and 222 with INR of 4.5. The patient received FFP also. So on subsequent follow-up at around 2 weeks, there was gradual trend towards the decline in the liver enzymes. Although this can be secondary, this can be by chance also, but only 1 patient we had data for this. So subsequently, this patient survived and she is also on our follow. So comparing with the other series of the dengue ALF, we had 1 series from India and 2 series from the Thailand. We see that our patients were more sicker and mortality in our patient is higher than the other series. The median bilirubin level in Indian series was bilirubin of 5, AST-ALT of 5,000 and 2,000, MELD score of 24, INR of 2.3, and mortality of 58. In other series, the bilirubin was 6.3, AST-ALT of 4,000 and 1,500, MELD of 25, INR of 2.4, and mortality of 59. Similarly, we also had a pediatric series also that in that the bilirubin levels were 8.9, AST-ALT of 7,000 and 3,000, and INR of 4.5 with a mortality of 50%. So concluding, the large proportion of the patients with dengue fever have liver injury. Proportion of patients developing liver injury is not influenced by the severity of the dengue. A small proportion of those with the liver injury develop acute liver failure, and the prognosis of acute liver failure secondary to dengue is poor. Prognosis in dengue ALF is probably determined the systemic illness rather than the liver injury itself. I would also like to acknowledge the role of our other departments who have managed the patients and also shared the data to us. The Department of Emergency Medicine, Critical Care Medicine, Department of Anesthesia, Pulmonary Medicine, Nephrology, CMS office, and all other departments for providing the support in patient management. Thank you.